What about breast imaging? During the height of the pandemic in the United States a year ago, we basically shut down all breast imaging unless it was some sort of real emergency. And again, it's the same reason. We wanted to minimize patient and provider risk. Now, but there were some patients who did require imaging, for instance, ultrasound for breast abscesses, or ultrasound or other imaging studies for serious postoperative complications. So we were doing limited imaging with this group of patients. The majority, though, fall under category B, diagnostic imaging for abnormal mammograms found just before the pandemic fully hit, or suspicious breast symptoms. Biopsies that were already done for BI-RADS 4 or 5 lesions, which were really high on the index of suspicion for breast cancer. Breast MRI for extended disease, particularly if we knew that somebody was triple negative or HER2 neu positive, we wanted breast MRI to determine extent of disease prior to starting chemotherapy or targeted therapy. Also, those with BI-RADS 4A, such as fibroadenomas, those biopsies could be postponed or delayed for some time under this categorization. BI-RADS 3, some of the fibroadenomas can be categorized here, or asymmetry seen on mammograms or whatever, or indeterminate ultrasounds. We felt that those could be biopsied until after certainly the peak of the pandemic. You've got to remember, this was all put together last year, early in 2020, where we naively thought, oh, well, the pandemic will last 3 months, 6 months. Gee, probably no longer than that, not realizing the extent of what the involvement was going to be, and the involvement here in the United States, Western Europe, and obviously worldwide. Category C then could be put off until, as I said, after the pandemic. Well, what about from a surgical oncology perspective? In category A, obviously, if we've got a breast abscess and the patients are septic from it, we're going to go to the operating room and operatively drain things that we could not do with needle aspiration at the bedside or with ultrasound guidance. Obviously, if we had a patient with an expanding hematoma, and we would go immediately to the operating room. So this is sort of the bigger category, and this is going to be a very, very busy slide. And I don't want to spend a lot of time on it, but I'll do some highlighted things. This was then broken down into the 3 subcategorizations of B1, B2, and B3. The B1 being the higher category. So if somebody had a autologous flap and it was ischemic, we would obviously try and revascularize or remove the flap. This would be considered a high priority. Or if we had a mastectomy flap that was ischemic and with exposed prosthesis, we would debride, obviously, and remove the expander or the implant. Or if we've had patients who have just completed neoadjuvant chemotherapy for inflammatory breast cancer, we would operate and perform a mastectomy without reconstruction as soon as possible, depending on the resources within the institution. Or if we had a triple negative breast cancer or HER2 neu breast cancer, and neoadjuvant chemotherapy and HER2 therapy, targeted therapies have been completed, we might do one of 2 things. If it was a small cancer, we might operate first, or we would get them started on their neoadjuvant therapy, or if they just completed their neoadjuvant therapy, we would obviously want to get them to the operating room. Under B2, this is getting into finishing neoadjuvant therapy, operative if possible, or change or extend the neoadjuvant therapy. So these two categories are sort of B1 and B2 are overlapping a little bit when it comes to neoadjuvant therapy for especially HER2 or triple negative cases. What about the lymph node positive or T2 or N1 stage 2 cases? If somebody is estrogen receptor positive, then we're going to, and HER2 negative, we're going to go to hormonal therapy and delay surgery. And we actually started at the American Society of Breast Surgeons a registry of these patients to see how they did. If we've got somebody who's got a discordant biopsy and we thought, you know what, this is really malignant, and getting back a benign biopsy result we felt was discordant, then we would proceed ahead with an excisional biopsy, a wire localization excisional biopsy where feasible, depending on the resources. And if we had a malignant or suspected local recurrence, we would try and stage the patients first and do excisions where conditions were allowed. Then under category C, and I'm not going to go through all of these, it's really important to remember that breast cancer is a huge galaxy of diseases. And so estrogen receptor negative ductal carcinoma in situ or positive margins, or a clinical stage 1 patient who is ER and PR positive, HER2 negative, we can delay operations, even though we wouldn't be able to use anti-hormonal therapy here. We can delay the re-excision. Again, remember, we were thinking that the pandemic would be relatively short and delay operation, essentially starting on anti-hormonal therapy. What about estrogen receptor positive in situ breast cancer? Again, delay operation until after the pandemic. Then the rest of these, reconstruction for a prior mastectomy, excision of fibroadenomas or papillomatosis, a discordant biopsy that's likely benign, or any prophylactic mastectomy, all of those can be delayed until after the pandemic. Now, let's switch categories, and because I'm a surgical oncologist, I'm going to highlight some things in the medical oncology and radiation oncology areas, knowing for those of you who are interested in greater detail, you can find these by getting the manuscript out. Obviously, at a priority A, where we've got basically urgent or emergencies, febrile neutropenia, this is considered a medical oncology emergency. Hypercalcemia, intolerable pain, symptomatic pleural effusions that would need to be tapped off and chemotherapy going, or brain metastases. These are considered emergencies for which the regular treatment would be offered. Now, this is a really busy slide. And I'm just going to highlight some of the things here in the B1 category and not try and go through all the details here, especially given the time it would be involved in going through all these. A real urgent situation is inflammatory breast cancer. Now, I want to draw a difference here between inflammatory breast cancer, which is a very, very unique entity, and locally advanced breast cancer. In locally advanced breast cancer, where there's a lot of nodal involvement, big tumors, you can get erythema of the breast because of lymphatic obstruction, but it's not the classic inflammatory breast cancer that sets in very, very rapidly, often with no palpable masses in the breast, maybe involved lymph nodes or not. Either way, whether it's a true inflammatory breast cancer or locally advanced breast cancer with inflammatory changes, we're clearly going to start neoadjuvant chemotherapy. And if it's HER2/neu positive, the targeted therapy to go along with that. As I've said, the standard of care currently in the United States, and I think pretty much worldwide, is for triple negative breast cancer. For those of you who don't know what that is, that means the estrogen receptor is negative, the progesterone receptor is negative, and HER2/neu is negative. That's triple negative breast cancer. Or in the HER2/neu positive breast cancers, chemotherapy, neoadjuvant chemotherapy with Herceptin family of drugs for the HER2/neu positives. Obviously, if we've got metastatic breast cancer with treatment likely to improve the outcomes, like initiating chemotherapy, endocrine therapy, targeted therapies, or as I'll talk in a few minutes, radiation therapy, we're obviously going to be doing those regardless of the circumstances during the pandemic. If somebody has started on neoadjuvant or adjuvant chemotherapy, we're going to continue the treatment until completed, and we may even extend the neoadjuvant chemotherapy if somebody's responding as a B1 sort of approach. If, in fact, we've got somebody receiving neoadjuvant chemotherapy or neoadjuvant endocrine therapy, and they're actually progressing in the face of this, then we're going to refer the patient to surgery or change what we're doing systemically. Under B1 also, if we've got adjuvant endocrine therapy, we're obviously going to continue it. In premenopausal breast cancer patients where we've got luteinizing hormone and releasing hormone therapies to suppress the ovaries, we'll do that. Or in the premenopausal, we can use aromatase inhibitors if it's combined with LHRH agonist therapies, and we can continue to lengthen out what we're doing. Or if they're just on tamoxifen, we can consider deferring LHRH agonists for these patients. And then stage one, I've already talked about this. And then the rest of these, I'll let you review the articles. Under the C category, most of these zoledronic acid for anti-absorptive therapies, we can discontinue those unless it's for hypercalcemia. Interval follow-up studies can be delayed in lower risk patients. Routine inpatient referrals can be done by telemedicine. Bone densities can be delayed. And so a lot of things can be delayed. So the real area for the medical oncologist, as I said, is basically on this slide.